an update on what SPPQ is, and also community and engagement, engagement partnerships update. Mie gagi na mo chikatan na ng kaya, ki wintam watch kayo naga na kiwatch, ko mina kaya ki ni pite wintam watch ka aysen kayo na yun ka pe motua chan kiune. We also heard from Vice President Regional Services Monica Hemian, ko kainin himang kiuntre gagatima, and we looked at an update and on Elders Advisory Circle and what Youth Advisory Circle is going to look like within SLFNHA. And towards the end of the day, you had a chance to meet with the medical directors, Dr. Yvette Emerson, Dr. Alana Morgan, there was a meet and greet within that area. We had a traditional fish dinner, a dinner banquet cake, and there was a celebration there for 35 years in health. Mr. Hian Kiwan here is Nagwan, Eki Matchtown, Eki Witamaguang, and guys now Matchtown. It was an honor to hear the beginnings of SLFNHA, and I'm in my 4th year, I think, in SLFNHA, so it was really nice to hear that where the beginnings of SLFNHA came from, and people that began the work as well. So we will begin the breakout session, so setting the stage. I will call Presidency of Sonia Isaac Mann, Jibukakitich. And I'm going to call VP Regional Services Monica Hemian and VP Community Services Janet Gordon and Ashley Pressinger.
Janet Gordon. And Sandra. Is she not paying attention? Okay, so we're going to get started here while Janet wraps up her conversation and joins us up here. Just want to highlight a couple of things from yesterday and why we're doing these breakout sessions. So Bobby presented yesterday on her engagement partnerships pathway and identified priorities that we've already heard from communities and from health directors and chiefs. Part of the, and you'll note in your package the green sheet that's asking you for some further feedback on what to focus on. Next, so part of the discussion today is looking at non-insured health benefits. We know that this is a priority area. We've heard from you multiple times at the AGMs as well as other sessions that we've been holding with communities. So Monica and Sandra will be talking about how we're engaged in this work already. And then the breakout session will be looking to get more feedback and input from you in terms of how much more involved do you want SLFNHA to be in relation to NIHB. And then at each of the sessions at 10 o'clock, there's going to be a question about the priority areas of NIHB and those, and you already know this. medical transportation, vision care, dental services, prescription drugs or pharmacy, medical supplies and equipment, mental health crisis counseling, and what am I missing? That's it, right? Going on memory here. So those are going to be really important conversations this morning around input from you so that we can have clear direction on how to move forward working with our ISK NIHB counterparts. Monica and Sandra will talk about where we're at already in terms of that work and the advocacy that we've been doing with our counterparts federally around NIHB. And then the second part of this will be talking about mental health and addictions. We know that this is a priority for all of our, so we've been doing a lot of work in this area already. Janet, where's Janet? Okay, Janet is here. So Janet is our community health vice president, and mental health programming sits with her. We've had a couple of shifts internally in terms of the work that was identified in the fall of 2023 with the establishment of a task force. So Ashley Presenter is also joining us at the table to give us an update on that work. We did elevate the function of that task force to be a part of my office now, so that I have more oversight in terms of the work that's happening there. So, because it is quite significant in terms of how we're going to move it forward and report back to the chiefs. So there'll be a more fulsome report as well at the AGM, as we'll be reporting against the resolutions from the chiefs. The other piece here is looking at how do we create a more coordinated, partnered approach to mental health and addiction services. So we have internally had a conversation at the executive level. So myself, Janet Gordon, Monica Hemian, and Brian Kalea, who is unfortunately not here this week. He's doing some family celebrations, so it's good for him. We are doing, and Janet alluded to it last night, we are doing some structural review of the organization to ensure that we have the right structure for the work moving forward. And Wally talked about this last night as well. We need to evolve as an organization. We're not the same as we were 35 years ago, and things need to progress. So we're working on that. One of the specific pieces that we've all agreed to is that mental health and addictions is a priority for the organization. So we are going to be restructuring to reflect that. What that looks like, we don't know yet. We're still in conversations. So we do have a session that will be facilitated on August 19th. And we'll be reporting back on the outcomes of that at the AGM as well. So just wanted to give you an update on that. So we've heard what you've said, and we're adjusting the organization accordingly so that we're actually structured the right way to respond to the feedback and input that you've provided to us. So with that, I'm going to hand it to Monica and Sandra to talk about NIHB, and then we'll move to the mental health addictions conversation.
Thank you, Sonia. I get to talk about the favorite subject, NIHB, the best department at ISK. I'm sure everybody agrees, right? So we just want to do a quick little land acknowledgement and recognize and thank Chief Bull for allowing us to come on Lac Seul First Nation, which is signatory to Treaty 3. The Health Benefits and Client Support Department is about a year and a half old now, and the lady to my right here is Sandra Linklater. She's the Director of Health Benefits and Client Support, and their purpose is to support our First Nations clients as they navigate the healthcare system and access the FNIB non-insured health benefit programs like medical transportation, vision care, dental care, pharmacy, medical supplies and equipment, and mental health counseling benefits. Also coordination, education, and supports to help to healthcare providers, tribal council organizations, and independent First Nation organizations. They do address racism and discrimination through Canada's healthcare system, through advocacy and support to First Nations individuals, and they provide language translation, resource sharing, and liaison services.
All right. I think just to get started with regards to what it is that we're doing so far. So we have established the Patient Navigation Program, which is the Menowichihiwe Patient Navigator Program, and they're responsible for the liaison and advocacy for First Nations members who request support on NIHB issues with and beside healthcare providers as well as patients and families. We provide translation services in Cree, Oji Cree, Ojibwe to English and vice versa, supporting clients navigating the ISC medical transportation, vision care, dental, pharmacy, medical supplies and equipment, and mental health counseling benefits. They support the clients by attending scheduled medical appointments as needed to ensure removal of the client's barriers to care by identifying critical resources and helping them navigate through healthcare services and systems. They also help clients communicate with their healthcare providers so they get the information they need to make decisions about their healthcare in their language that they understand. Provide support before, during, and after appointments. They investigate incidents, addressing their concerns and complaints. They work jointly on resolving issues with internal and external agencies. They support their clients through appeals processes when denied. So the Patient Navigation Program has been around for this is going on its 4th year now. In 22-23, they assisted 229 clients. Primary services, so when we talk about primary services, the primary reason why the patient navigator was sought out could have been for translation, could have been for advocacy, could have been for a resource that they needed, could have been they needed help with something. So, and along with, it's not usually just one service that they're asked for, they're asked for secondary services, so translation, advocacy, resource sharing, I need you to help me with the pharmacist to come and interpret for me for my medication that I have to take. So that's what we mean when we talk about primary and secondary services. In 23-24, we assisted 859 clients of primary services, and then the secondary services was 285. And then in 24-25, that number jumped to 2,141 primary services, secondary services of 802, and then our after-hours program, meaning anywhere from 6 p.m. to 10 p.m., is 333 services that we provided in 24-25 for our patient navigators. So in Sioux Lookout, we have 4 patient navigators, which is Barb, Zebedee, Leona, and Alice. In Thunder Bay, we have Leoncia, Jackie, and Evelyn. And then in Winnipeg, we have Willie, Elisa, and Clarence. And they are all language speakers, whether it's Cree, Oji Cree, or Ojibwe. So if a client reaches out and if the client is completely Ojibwe, then we have an Ojibwe translator there that's available. So the link that's in the document takes you to our website for SLFNHA. That does provide you with all of the information that you need on how to contact the patient navigator, which is one phone call. So our patient navigator program is headed by Wendy McKay, and her contact information has been provided there for you. Now, I'll let Monica speak to our advocacy tables that we've established since June 2024. Thank you.
So a lot of these tables have been recently convened in relation to the issues that they're having at NIHB over the last 1.5 to 2 years. It was quite evident that they were running into problems, and we started advocating right away, but they finally kind of took responsibility about a little less than a year ago. So some of the tables that have been started are the SLFNHA Physicians Working Group. They've had 11 meetings so far, and both Yvette and Alana sit on that table along with Sandra. The ISK SLFNHA various benefit areas including vision, dental, and updates. There's been 11 meetings and Sandra attends on our behalf for that. The SLFNHA Tribal Council and Independent Technical Table, they've had 7 meetings. From SLFNHA, Sandra, the manager of the Navigators, Wendy, one of the associate directors of the hostels, Karen, the Indigenous Transitions Facilitator would be attending that. That's our nurse discharge planner, and then the tribal councils. So that's how the tribal councils are getting updated on all of the various tables as well. Then there's the ISK and SLFNHA executive table. That meeting is the higher level executive from SLFNHA, Sonia, Brian, myself, along with the executive at ISK as well. There's the ISK SLFNHA Regional Steering Committee table. They've had 3 meetings. No, there's been more than 3, sorry. There's probably been about 8 meetings in that one. That one is Brian, myself, and Sandra. And then the ISK, SLFNHA, WAHA, Wekwadon, IPS, Northwest and Northeastern Ontario meetings. Those were started by Indigenous Services Canada, and Sandra had to urge them to do that, just to keep all the service providers in the area aware of the issues that they're having.
Back in July of 2024, we met as a executive table with ISC executive. And at that table, we had addressed specific concerns related to non-insured health benefits in the Northwestern Ontario region. And specifically, we're talking about unprocessed travel for clients attending scheduled medical travel, which resulted in no-shows. Clients showing up at the airport with no travel processed. They would go to the airport assuming that their travel was being processed, but when they got to the airport on the day that they were supposed to travel, there was nothing there. NIHB was not picking up the phone, messages were not being returned, no responses to client queries or even physician queries. There was no process for appointments that have no travel process. So in other words, if I had an appointment and there was no travel processed and I showed up at the airport, nothing there, I went home, what happened to that appointment? So there was no notification to the physician's office that I was supposed to attend, that I did not attend that appointment because there was no travel booked. So then that ended up resulting in high no-show fees for our clients. The next time they tried to go back, they say, well, you were a no-show for your last appointment. We're charging you $500, $200, $100. So no information in the MTRS system or appointment system when a client calls. So basically what that means is that the MTRS system is the ISC Medical Transportation Record System. There was no way for them to tell me how many appointments were missed because there was no travel booked. They could not tell me how many people, they couldn't extract any data from their system to tell me how much was unprocessed. So I said to them, I said, so basically you're telling me that there's a piece of paper sitting in your system, whether it's digital or whether it's on the corner of somebody's desk, that transportation was not processed, but that client's appointment notice is still sitting in your office. And you can't tell me how many of those appointments were not processed. And they said, no, there's no way our system can do that. So there's a lot of unknown tracking for upcoming appointments. So when they do their processing, it goes into a digital file or it goes into their filing system. So regardless of how much advance notice I give to ISC to tell them my appointment is October the 15th, here's my notice of appointment for October the 15th, and the assumption is that I am going to get my travel in a timely manner. But no. So we'll talk a little bit more about processing by ISC for medical transportation later. So clients are being told that there's no booking of flights, that because there are limited seats, clients are being told there's no room on the plane, which is contrary to what the clients are being told by the local airline. So we think about, is ISC designated a certain number of seats that they're allowed to book, and once they go beyond that designated number of seats, then they're told that the plane is, that their seat allocation is full. I asked that question to the ISC director for medical transportation. Says, no, that's not how it operates. I'm thinking, then why is it that when my client goes to the airport and that plane is not full, they're being told by the agents that there are seats available, but meanwhile ISC is saying that there's no seats available. So there's a lot of contradiction happening there. Missed specialist appointments resulting in clients being penalized by the provider as a no-show. Client is required to be reassessed and a new referral being generated, which is a very lengthy process. We already know that 1, 2, 3 appointments missed, you'll have to go back and get retested, reassessed, you'll have to submit a new referral, and then by the time we have the individual being seen by the specialist, it could be too late. Delayed diagnosis, right? The communication system. ISC issues are not communicated. The system was down for 10 days. For 10 days, they were completely silent to us. They were completely silent to our physicians. When we had submitted urgent requests for transportation, there was no response because their communication system was down. They didn't tell us that it was down until we went to them and they told us, oh yes, our system was down. For 10 days and you didn't tell us? So they do have archaic systems requiring a review on how paperwork is processed. So their phone systems are bogged down. They're being hung up on after. So when a client calls and you know that there are lengthy wait times for a client to receive an answer to a call, they're being put on hold. Once a certain period of time passes while you're on hold, the system will automatically drop the call. Or they have a callback feature. You leave your name and your number, you don't get a callback until maybe there is a break in between there. Why can she not go to Dryden for an optometry appointment? Why can she not go to a dental appointment while she's here? So there's no client coordination between benefits. The expectation is that that client is going to take responsibility for themselves and make their own appointments, but then ISC says, well, the rule is we have to know about that appointment before they leave the community. So it's like there's just no client coordination between the benefit areas, and they make it extremely difficult for you. So we do have a lot of ongoing key issues that we have been addressing at all of our working tables. The non-responsiveness to clients when requesting information on travel arrangements. So if I call ISC and I want to know about my travel and they say, oh, it's not in the system. It's like, what do you mean it's not in the system? I gave you the appointment notice 3 months ago. Non-responsive to requests for data. And that is specific to my function. I need to know how many appointments are being processed, how much travel is being processed, because how can I advocate if I don't have the data? And they're non-responsive to data requests. ISC for processing. However, ISC does not acknowledge receipt of documentation to the sender. So this is specific to our physicians group. They talk a lot about processing. We can do it better. We're doing it timely, but they're not, because there's no confirmation that the travel was processed. So there's lots of stuff happening, going on. Requests for benefit process maps. We've asked for benefit process maps for medical transportation, dental, and vision. How can you, as a community member in whatever community that you live in, be proactive for your own care if you don't know what the process is? We've asked for a standards review analysis by ISC and their offices. We've asked for travel processing being 0 to 2 days ahead, where staffing has been added, but there's been no improvements. And benefit analysts are rude, culturally insensitive. So I'll let Monica take over from here.
So we definitely can go on and on and on. You'll see that Sandra has made about 5 slides of the issues that we deal with. And I'm sure all of you as well have your own individual story. Know that there's issues going on. I'll just keep sliding through the slides here, but we do want to get your thoughts and your feelings and your opinions and your stories when we do go out into the breakout rooms, but we really want to hear from you what you can see us doing in this advocacy that we're doing with Indigenous Services Canada and specifically NIHB. But we just wanted to share with you that we are working hard to try to get the issues resolved. As soon as we find out that there's a system issue, then we make sure we talk to the right people at ISK to make sure that that system change happens. So there's our names and our emails again. Most of you have my phone number, but I can definitely share that with you. It's 738-0549, and Sandra's phone number is
738-6157.
So we're going to move into mental health and addictions with Janet Gordon and Ashley Pressenger. And right after that, we'll move into our breakout sessions. So we're scheduled to take a break at 10:45, which will transition you to the second breakout sessions with different questions. So we want to keep the time mindful. Yeah. Okay, Miigwech, go ahead.
Even with glasses, I can't see. Good morning, everybody. So we just want to give a quick update on the work that, too close. The work that we've been, that we're doing on mental health and addictions. As you know, that the communities continue to see this issue around mental health and addictions just continuing to rise. I think every day there's crisis situations that happen. The communities have put forward resolutions to deal with mental health and addiction. There has been work that has been done, but just like the non-insured health benefits, the government, especially the federal government, we have not seen any increased funding around mental health. So we try and provide service with the resources that we have. There was a little bit of money that came to tribal councils, but around 500,000 each, and that doesn't go far. We have lots of crises that we work together on, but we still are not able to adequately meet the needs of the communities. So as you can see, over the last 10 years, there has been resolutions, there has been discussions, there has been work done to really identify, how can we move forward, and what do we need to do? And one of the things around, I think the latest thing was that we did, we have done some reports. So at the Health Authority, we do have Noden Mental Health Services, which have did get some increased funding through Jordan's Principle. We haven't received the funding for this year, but continue to provide that service. And I know that communities are also have not received their funding through Jordan Principle funding, which is those land-based programs and services that are so critical for the communities. We do some work around approaches to community well-being, around promotion and prevention. Primary care team also does some work and developmental services around children's. And of course, we have physicians that go to the community. And SLFNHA also provides services. And then we, with the task force, has been moved to SPPQ unit, and they've been able to do some good focus work there, and which is the Mental Health and Addiction Project. So the next slide, and our community members suffer the most from mental health and addiction, and they access services at the community, at the hospital, and I think, you know, there is some work that has been done. I think we're a little bit traumatized yesterday by the mayor's report. I was thinking about it, and I was trying to think of it as okay, well, you know, he had those case studies where somebody was, you know, had police interaction 200-something times, and that was one person. So maybe it's not as bad as it looks, if it's, you know. But I think people would access services if we had more treatment services. So we do have a proposal that we developed, and it's been there for 2 years. Nothing. We have not heard anything. We submitted to Jordan's Principle funding, and that's what we were encouraged to do. And that was with partnership with Eagle Lake and KDSP. So I think, so as you can see, there is some stats on the next slide. I think those has been circulated to all the communities, and I'm trying to think if we did community-specific reports, because sometimes we're able to do that unless the numbers are really small. And I think you can see like increase sort of access that people have. So they are seeking help, which is a good thing. It's not a bad thing, I don't think, when people are seeking help, and that we'll just continue to work within our Noden program and work with different departments. We're starting to look at how we can pull or work together better as within the organization, as well as with the tribal councils who deliver a bit, you know, some services with you know, a little bit of money they have. So I'll pass it on, I think. Sonia? Yeah.
So I've already mentioned this, but just want to highlight one resolution in particular. So this is resolution number 23-8. So this was at the AGM in the fall of 2023. It was the declaration of a public health emergency and social crisis to address mental health and addictions among Sioux Lookout Area First Nations. So this is the resolution that came from the chiefs to really pivot the work towards this task force project and looking at how we can actually address some of these issues. So a couple of areas that were highlighted in that resolution was to develop a media and an advocacy strategy, form the joint task force to address the ongoing mental health and addictions crisis, which is formed, seek funding from Indigenous Services Canada to host a mental health forum. That funding did come through, and we did hold a mental health forum in the fall of 2024. And to move forward with a strategy that does not interfere with community or tribal council lead initiatives currently underway. So that model, Janet referred to it on a previous slide. We'll be talking about that as we move forward. Ashley is leading the work and supporting the task force. Myself and Janet participate on that table as well. And then the other piece here really is around calling on the federal and provincial governments to step up to the plate and allocate appropriate resources to address mental health and addiction issues in this region. So we continue to do that. I'll just tell you one little quick story. So Minister Chibolo was here, a year and a half ago, announcing some funding for treatment services within Sioux Lookout to increase beds, but no capital dollars. So how do you operationalize treatment beds when you don't have any infrastructure to do it, right? So there's some definite issues and barriers to implementing programs and services when federal government and the provincial government don't actually allocate the appropriate resources for the right reasons. So, I mean, if you're looking at a residential treatment bed type of service and you have no building, you can't operate. So that's just one example, and I'm not going to go into the multitude of others because we're short on time, but I'm hoping that we can have that conversation during the breakout session in terms of your input and feedback around where you see some of those barriers and how we can address those. So I'm going to hand it over to Ashley to talk about the work that the task force is doing.
Hi, everyone. I just want to thank everybody who's sort of welcomed me into this position, tribal councils, community members. Chief Wesley was kind enough to welcome me to Cat Lake to do some of this work. So I just want to thank everybody for that. So we did host, as Sonia said, we did host a mental health and addictions forum last November. From that, there were several key themes that came up. There is a report that was published, and from that report, we're working to implement a number of those recommendations. Those recommendations align with both the model that I'm going to show you, but they also align with the recommendations from the 3 reports that Janet identified. So the forum was great in sort of identifying additional recommendations, steps, leading to what's going to hopefully be a co-developed strategy for looking at mental health and addictions in the region. As it was mentioned, we have a mental health and addiction task force. This is one of the directions that came from that resolution in 2023. So the goal or sort of the role of the task force is to provide oversight, direction, advice, and really help guide where this mental health and addiction work is going. So the members of the task, can you just do the switch? Thanks. Yeah. So these are the members of the task force. We're happy to add more people. If there's someone that you think should be on this task force but don't see on this list, we're absolutely open to adding more people. We do have a vacancy for youth, so if anyone has a youth in their communities that they know of that they would like to participate in this work, we're happy to have them. The task force is meeting quarterly at this point. We are hoping to have an in-person sort of meeting to look at what the strategy could potentially be, as well as the upcoming work plan. So again, this is the task force, but if someone wants to join or be a part of this work, we'd be happy to have you. So the model that we've been referencing is right here. It was developed in collaboration with individuals that attended workshops, forums, sort of individual surveys. So this was all done with community input. So in the yellow circles is the priority areas in mental health and addictions. So each of those priority areas have corresponding recommendations that were developed from the 3 reports that Janet mentioned. So each of these yellow areas have been identified as a priority to reaching mental wellness in communities. And then again, we have recommendations for implementing each of those areas. So this next slide is the project charter. We've developed it just recently with feedback from the task force, as well as looking at what the goals of this project really are. So again, we're mandated by the resolution 2308, which is directing this work. But I do also want to mention that there are 21 other mental health and addiction resolutions that is also going to be incorporated into this work. So we're going to identify what resolutions have sort of been accomplished, what areas do we still need to do some work on, and what resolutions do we need to be carrying forward to continue doing this work. So I won't go through all the goals or activities, just out of interest of time, but we do have goals identified for this project. We have completed several activities, so most of that resolution has been completed. We're working on sort of an advocacy and stigma campaign to address mental health and addictions. But a number of those sort of activities have been accomplished. We are working with OSHGI and 7Gens to look at developing training specific to mental health and addictions. We're doing a mapping of mental health and addiction services in the region, so not just by Indigenous organizations, but from sort of all regional partners. And we've been able to host meetings with various regional partners to discuss this work. And we have several proposed outcomes. Ultimately, we're looking to support mental wellness in communities. So the goal of this project and the goal of moving this work forward is really to determine what does mental wellness look like and how does SLFNHA support in achieving that. So as I mentioned, we have several partners. So this project under Sonia's SPPQ team is looking sort of as the organization in terms of what do we do internally with mental health and addictions, what can we do better, and what services are working or maybe not working. So internally, this project is partnered with pretty much every department that SLFNHA has. We are working with NODN, ACW, developmental services, the HR team, which is the human and people and culture. Leadership is obviously involved, PCT, and then physician services. So SLFNHA recognizes that mental health and addictions is part of absolutely every department, and that it's not just something that's separate or it can be addressed on its own. So it's really looking at all of the different pieces of mental health and addictions and how does SLFNHA do in those roles. Externally, we've developed quite a few partnerships. We're working with Minneawan, the Thunder Bay Regional Health Science Center. We're hoping to be working with the hospital in Kenora as well to sort of determine what are the best steps for supporting someone that's in a mental health crisis. Again, the tribal councils have been fantastic. They're very much willing to engage and participate in this work, so it's been really great interacting with tribal councils. Communities. I've been able to communicate with several communities, and there is a goal of doing service mapping in each of the communities when sort of this foundation piece is done. We've been working with WAHA and First Nation Health Authority, so working with other health authorities. Government funders have been attending meetings, so I've been hosting meetings with treatment centers, different service providers in counseling and therapy. And ISK in the province have been interested in attending. So they do recognize the need, but they don't necessarily have funding to support broader work. We've been working with different non-for-profit organizations. The Indigenous Education Institute, so 7Gens and OSHGI are super supportive in this work. And regional treatment centers. So like I said, I've been meeting with the treatment centers in the region to see how we could better coordinate access to treatment, what does post-treatment and pre-treatment look like, and how can we start to address the concerns around detox before entering treatment. So those are just some of the partners. Our contact is on there, so Jennifer Desrosiers is the Senior Director of SPPQ, and then myself, who's managing this project. We're happy to hear from all of you, from any of you, and we're really looking forward to this being a collaborative approach to addressing broader systemic issues around mental health and addictions. So thank you for your time.
Testing. Miigwech for your presentations. We do not have time for any questions, but you'll have that opportunity during your breakout sessions. Miigwech for your presentations, and we'll continue our discussions in our circles. Okay. What we're going to do now is we're going to resume to the breakout sessions. If you do not have a sticker, please raise your hand and we will come to you. Inabiyog on your badges. See if you have a colored sticker there. If you do not have one, please raise your hand. And what's going to happen now? It's 10:13. So what's going to happen now is session 1 is on non-insured health benefits in IHB program. There's 3 questions there. What should SLFNHA's role be in the call is on that side. Ego min orange wetneke. Inabiyog on your badges. So your session starts at right now, and then your break is going to be at 10:50. From 10:50 to 11 o'clock is your break. And at 11 o'clock, we will resume for session 2, mental health and addictions. There will be a facilitator there. Somebody has their hands up there, needs a sticker. Keep your hands raised and someone will come to you. Okay. So red circle on this side. Green circle is on that side. Blue wet neck, blue orange wet neck. Maya waga ke bantawat yun listen ke kun hima katasantanawa. So you have until 10:50 to discuss amongst yourself on session 1, non-insured health benefits and IHP program, those 3 questions. And if you have, I know time is of essence. If you have any more information or anything that you want to add, you can reach out to Sandra Linklater or Monica Himian. In their presentation package, there's an email address there, contact information. So please make your way there. Does everyone have a sticker? As nagkakinagimino ko na a sticker.